जी, आवाज़ आ रही है आपको मेरी?
यस यस सर।
अच्छा, मैं थोड़ा-सा अभी लेट हूँगा, मैं सदफ को बता रहा हूँ कि 3:10 पे अगर शुरू कर लें या 15 तक, मैं स्क्रीन शेयर अब करूँ। आवाज़ आ रही है आपको मेरी क्लियर?
जी आवाज़ क्लियर आ रही है। ये सामने ना आपको ग्रीन कलर का बटन शो होगा। बिल्कुल ठीक
हाँ जी, अब क्या आ रहा है? अब सामने आपके आ रही है स्क्रीन?
है। जी सर आ गई है, स्क्रीन आ गई।
स्क्रीन में प्रेज़ेंटर को प्रेज़ेंट करूँगा तो अभी तो ये नीचे वाला भी लिखा आ रहा होगा। अभी जैसे स्क्रीन है ऐसा आ रही है वैसे
प्रेजेंटेशन
भी।
प्रेजेंटेशन व्यू में कर रहे हैं।
हाँ जी, देख रहा हूँ। स्लो है थोड़ा सिस्टम, पता नहीं इंटरनेट स्लो है या फिर।
अब ठीक हो।
अब मेरी अपनी वीडियो भी आनी चाहिए कि मैं अपनी वीडियो को, ये मेरी वीडियो साइड पर सामने स्क्रीन है ज़्यादा जो है अभी। नेक्स्ट स्लाइड करनी होगी तो सिंपली नेक्स्ट, लेकिन
जी
मुझे ये गायब कैसे करना होगा क्योंकि मेरे कुछ जो बातें उन्हें पढ़नी हैं।
क्या करना है आपने?
अगर अपनी जो वीडियो है ना मेरी, जिस तरह उसको मैंने छोटा करना है ताकि मैं स्क्रीन से सामने जो नजर आ रहा हो गई छोटी, ठीक है। ठीक है। मुझे बस अभी 10 मिनट दे दें, सिस्टम तो चल रहा है, मैं ज़रा रिव्यू कर लूँ इसको। कितने बजे हमें ऑडियंस में?
मतलब 3 बजे आ जाएंगे। 3 बजे का टाइम, 10 मिनट है।
हेलो, 10 मिनट और। हाँ जी, मैं बस आता हूँ 3 बजे, ये सिस्टम ऑन ही रखता हूँ
जी ठीक है सर।
मैं 3 बजे, 3:05 तक आ जाऊँगा, आ रहा हूँ बस।
जी
पेशेंट
ठीक
आए
है।
हुए हैं और मैंने
हाँ
सदफ को बताया कि थोड़ा सा लेट हो रहा है।
ठीक है, मैं डॉक्टर सदफ को मैसेज कर दूँ।
Can you hear me now? Hello? Can anybody reply back to me?
Ji, Assalamu alaikum, Dr. Usman. It's Dr. Sadaf here. We can see you and we can hear you loud and clear.
Good, excellent. I'll just share my screen and get started.
Thank you very much for your time, sir.
Right, you can see the screen.
We can see your screen, sir.
Excellent. Assalamu alaikum, everybody. Dr. Usman Bashir here, and it's lovely to see all of you. And thank you to Sadaf for inviting me to give this talk. I just got stuck quite badly clinically, just in the last minute. That's what usually happens, you know. So excuse me if due to fasting plus being busy just in last half an hour, it's a combination of two things. If there's any deficiencies, you can still hear me? Yes, Sadaf?
Sir, we can hear you.
Good,
Thank you
good,
very
excellent. So I've kept this talk relatively simple. What I did, we just did a literature search of over last 5 years papers which have come out in the domain of acute pain, and give it a thought that which ones will be more applicable to practices in the regions where you are practicing in Pakistan area, and which things will be applicable, and came up, there were 3-4 papers which were more recent in the last 5 years, which I initially selected. But the ones which I find more relevant to be talking more about in this talk are going to be the one highlighted in red. One of them is a broad area, that post-operative pain management in non-traumatic emergency surgery. It's a broad area. It's a challenging area. So basically, we are talking about emergency laparotomies, any emergency bowel surgeries which are non-traumatic, and their pain management is a big area. So there was a quite a major guideline came up in 2022 defining all the areas. Second main one, which I think is very relevant and which is somehow still underutilized in pain management, is ketamine. And there has been a recent paper in 2018 with very good, excellent consensus guidelines about all the questions related to ketamine. So I thought that that will be another useful area. So these two we can use for today's talk. Of course, acute pain is massive and very broad area, so we cannot cover everything today, but in discussion, we can have useful talk about various components. So this is the first paper, which was consensus guideline between various renowned bodies and published in Emergency General Surgery recently. The purpose of this paper was that even the centers where the pain services don't exist, they can still manage the post-op emergency laparotomy pains effectively. And that's very much applicable in the areas where we all practice, in the developing areas, in the DGHs. So what I want to take out from this talk for myself and for all of you is not about learning about all these components which we are talking about, because these are the basics, we all know about it. Because the guidelines are recent, so what we can take out of them, that how we can apply various components into our areas of practice where we work, where the equipment, what drugs are available. And since these guidelines are recent, so therefore we can very much use this as evidence base for our policies, procedures, guidelines, audits, and research. So these are the various areas which are covered by these guidelines. The scope of this talk is not about going into pain assessment management, etc., but it's only what is relatively new or what these guidelines are emphasizing based on the level A evidence. Okay, so these are the main heads we'll be talking about. First area these guidelines talked about in the context of emergency general surgery, which is non-traumatic, is about pain assessment. With all you being pain experts and pain fellows, I don't need to go into details of pain assessment itself, but what is emphasized that generally speaking, emergency surgery is associated with more severe post-op pain. And as soon as you can start the assessment process, the better it is. An assessment includes validated pain tools, whichever is validated by your organization. And you adjust the pain management in a way that you have greatest effect with lowest side effects possible. I will speak a little bit more about this point in my coming slides, especially in the context of some of the things when we manage the things in Pakistan. Preemptive analgesia is a viable option in reducing post-operative opioid consumption. Again, we'll talk a bit more in detail about these two concepts, preemptive and preventive. At rest versus on movement. So that is another big area in terms of assessment. Can you still hear me? Everybody with me? Sadaf, just double checking.
Yes, sir.
Yeah, good. So I want you all to focus on this slide. So this is what is coming as a new thing in the assessment domain that focuses now more on the functional activity scale rather than aiming to have the term that, okay, pain-free or complete pain-free, or overemphasizing on the pain scores that we want the pain scores to be 1 to 2 out of 10 versus mild, moderate, severe. So emphasis is now on you titrate the pain management according to what could be functionally achieved. And you start the pain assessment, when you start the pain assessment process, you educate the patient according to these functional activity scales. So in other words, you're trying to give realistic expectation to these major surgeries that to avoid using terms like pain-free or zero pain or no pain at all, whereas you tell them that our aim is to achieve a certain functional activity, and as long as your pain is not limiting you to achieve those activities, that is our first goal. And that is more realistic expectation than patient has, and then you are goal oriented. And so this is one example of functional activity scale that is there is no limitation, patient is able to take activity without limitation. Now activity is defined by the type of surgery. For example, if it's laparotomy, then the activity which you want to see is deep breathing, coughing, mobilization whenever it's realistically possible. And if the pain is significantly limiting those activities, then you want to do something about that pain rather than just over ambitious trials to achieve a certain pain score or to achieve pain-free zone. And that is very much in line with the enhanced recovery program, which are coming up now, that this to have a goal as a functional goal. So take home message from assessment part is for all the fellows and pain people is to, in your institutes, initiate and start some sort of functional activity scale and start educating your colleagues, nurses, and start doing audits about that once you introduce these scores. The rest of the things in the paper are more about general comprehensive thing that any patient who has chronic pain is obviously associated with more severe acute post-operative pain. Therefore, attention should be paid at all these elements of anxiety, depression, catastrophizing. The last point, which is very important and which we stress on, and I'm glad that this guideline addresses, that whatever your local policy is or local guidelines are, always include reassessment in that, in the context of acute pain as a mandatory step within the assessment part. So that is the second major take-home point message from these guidelines and for myself and for you all. This wheel I always include in any pain talk for the fellows. This highlights just in a very summarized way the problems you go into if you do not control pain adequately. Now, the reason I've got it in the assessment, because uncontrolled pain can cause all these events like poor respiratory function, thromboembolic events, tachycardia, ileus. However, if the pain is adequately controlled and still you are getting some of the features which are relevant in these areas, then they can also highlight that there is some other problem going on surgically. So a comprehensive pain assessment is not only about pain assessment itself. A lot of time we end up picking up immediate surgical complications, which are out of context from that time zone where you are checking the pain. So that also comes within the pain assessment area and more holistic approach. I'll just now move on to various aspects where the guideline covers different types, categorizes various areas. As I mentioned in the very first slides, there's non-opioid drugs, opioid drugs, multimodal, regional anesthesia, route of drug, how these all are combining together in emergency surgery context and how you can apply it in your setup based on these recent guidelines. The whole consensus of international groups and bodies is to reduce the opioid use as much as possible. And that is why all this drive towards multimodal pain management, opioid-free analgesia, because they want to reduce the side effects associated with single opioid use. Plus, in the developed countries, there is all this opioid crisis going on, which a big part of that was uncontrolled discharge, post-operative discharge drugs. They were given opioid in an unchecked manners discharge time. So that's why there's a lot of drive towards all these multimodal regimes based on opioid sparing due to opioid crisis. So the definition of multimodal, you all know that it's based on that you use different classes of analgesic medication with different mechanisms. And the rationale of that you use those additive or synergistic effects so that you can reduce the side effect of a monomodal intervention. And as I said, that main aim for all this drive was to reduce the opioid use. And that's why a lot of these studies which have been done in this context are commenting more on the reduction in opioid rather than the contribution from individual multimodal component. And that is why an optimal multimodal element has not been definitely elucidated. These are all the various options we all know exist. We'll just very briefly go through the relevant ones, which these guidelines suggest what is the role of each of these and where do we stand and what can we do at our end. I'm not going to go into acetaminophen, we all know about it. The important thing about acetaminophen, which came out in this paper, was that if you give it at the beginning of the procedure, preemptively, rather than once the incision has been made and then you give it. So you use it in multimodal context, but use it preemptively. So I'll talk in coming slides a little bit more about preemptive and preemptive and preventive analgesia. It is an important concept for fellows and those who are going for exams. So preemptive is the defining point is basically you are starting the intervention before the stress or insult has occurred. So any treatment which you start preemptively, like before the surgery, can also be preventive. So these are the two common terms used in acute pain management. So preventive, on the other hand, is any analgesic intervention whose effect lasts beyond the duration of expected duration of action of that intervention. I mean, pharmacokinetically, they define it as 5.5 half-life from research point of view. But in simple terms, what you're doing is you're continuing that analgesic intervention as long as the painful insult is expected to last. So again, preventive, it's not necessary that you're starting it before the surgery. Whereas with preemptive, you're always starting it before the insult, and you can carry on. If you carry on that intervention further along the post-op period, it becomes preventive as well. The classic example can be if you site a thoracic epidural before the surgery and start the infusion before the infusion has occurred, and then you carry on the epidural infusion on day 1, day 2, day 3. So you maximize the duration until you expect that there is some sort of surgical painful insult is going on. So I just thought that there's much more details about these two concepts which you can read in books, but just to have an idea about these two terms in context of acute pain and in context of paracetamol, acetaminophen, it is better proven to be given preemptively. In multimodal context, they combined acetaminophen with naproxen and pregabalin in emergency general surgery. And what they found, there was a significant reduction in opioid side effects. Duration of length was shortened, opioid-related complications were much less. So next big area is NSAIDs and their use in the context of emergency surgery. We all know in the elective colorectal surgery, yes, they do have a good proven role and they reduce the length of stay and they have a place in the enhanced recovery protocols. However, in the emergency surgery, they found significant problems, as you can see over here, in relation to the use of NSAIDs. Increased wound dehiscence, there were technical failures, wound healing inhibition, specifically with the colon or rectal anastomosis, there were problems. And in a lot of studies, the NSAIDs associated adverse effects were underreported. So what this paper suggests that in the context of emergency surgery, it is impossible to define that there is a high level of safety of either preventive or preventive NSAIDs in emergency abdominal surgery. They did quote some studies where they found ibuprofen 800 milligram in the multimodal context to be decreasing the morphine requirements post-operatively. But overall, they made this blanket statement that it is impossible to define with high level of evidence the safety of either preventive or preventive NSAIDs. Coxibs, on the other hand, COX-2, they found to be effective and have opioid sparing effect. Immediately after major gastrointestinal surgery, they improve the VAS scores. Third main area is dexmedetomidine, and the evidence suggested that when dexmedetomidine was combined with fentanyl-based PCAs, they found it to be as effective as patient-controlled epidural analgesia, which is quite big if you think about the intervention comparison. Plus, with this regime, you are not having as much hemodynamic instability as with epidural, and invasiveness is less with this technique. So next big area is ketamine. So ketamine, I'll not spend too much time here because it is freely available in Pakistan and Asian regions. I've just included a recent paper on that, and we'll talk more about it. In a nutshell, it is beneficial in the emergency general surgery, and it reduces opioids. We'll talk more about it in the coming slides in a separate paper. Intravenous lignocaine is very much back in fashion. It's overall underutilized, I think. Still, we can use it much more higher in acute pain settings in Pakistan to have advantages where opioids, to have opioid sparing effect. Especially in the colorectal surgery, the evidence is strong now, and it is becoming a part of enhanced recovery programs. Traditionally, it was proven to be effective for these types of pain. And when the interest started coming back with these complications with epidurals in the last 10 to 15 years, there were more research done recently. So recent evidence was from 5 meta-analyses, and one big one was this Cochrane review. So the meta-analysis were mostly about safety studies. There were 17 studies which only looked at the adverse effects associated with lignocaine infusion for acute post-op pain. They did not find any major adverse effects. However, you do need more larger systemic analysis to comment finally on that. Clinical effectiveness was found from those meta-analysis dose to be 1 to 2 milligram per kg, both as bolus and infusion. However, they were unable to conclude what is the final maximum duration to have significant impact. Most studies carried it on to maximum up to 48 hours in the monitored environment. So that is another downside, that you do need a monitored environment if you're running a continuous infusion for long duration. This is the more recent one, where they included Cochrane reviews on 45 randomized controlled trials, all for laparoscopic, 13 for laparoscopic abdominal and 12 for open abdominal. And what they found, that overall it reduces the pain scores, and it is especially beneficial in early post-operative phase. So low to moderate evidence, which is good enough evidence to introduce in the practice. And it had impact, particular interest for colorectal surgery, because introducing lignocaine had impact on gastrointestinal recovery. And as a result, it has effect on reduced ILS, reduced length of stay, as well as, of course, reduced length of opioid requirement, which was the main goal for all these multimodal regimes. Gabapentinoids, it is conflicting evidence. It is not conclusive, because overall heterogeneous and conflicting statements come from various trials. What they did find, that if you preemptively introduce it and continue it in the post-op period, it could overall reduce the opioid consumption. But it was not conclusive. However, it can still be introduced in select population. So this is a busy table, but this is just to summarize all the multimodal modalities available in the immediate post-op period, one of the tables from this paper. Some of these things I'll talk about in the coming slides, for example, wound infiltration, epidural, and regional. So this is a summary of advantages and disadvantages of each group, and then you select based on your clinical environment and the patient group available what you're dealing with. But the main problem with any multimodal regime is this, that in the research area, in the academic area, you cannot carry out randomized trials to determine relevant importance of which component provided which type of benefit. Therefore, they were not able to define exactly that this combination is the best. They just use blanket statements like that overall multimodal improve the reduce the opioid consumption and improve the overall side effect profile. So that is the limitation of research that is practically not possible. A quick note on opioid drugs. Again, we are not going into theoretical details of which opioids to use. I'm talking about more in terms of what has come up recently in the evidence-based paper. A lot of areas in developing India use infusions. However, this paper goes against infusion, that this is infusion of opioids using intravenous patient control analgesia should be avoided, rather like in opioid naive patients. Most of our patients are opioid naive. They've not been on opioids. Opioids do have a central place in management of acute severe pain. However, there is a worldwide opioid crisis going on, and therefore it is important whenever we are selecting an opioid for post-op pain relief, it is for the minimum period possible. The use of patient-controlled analgesia is evidence-based, is effective and useful. However, these guidelines suggest against using the infusion of opioids. Within PCA, there is no clear evidence from the studies using this paper that whether one drug is better than the other, like fentanyl versus morphine. They were not able to prove benefit of one over the other. And in this paper, they say that if you are in setups where you do not have an EPC available, then you can use transdermal fentanyl. However, in some of the larger group studies, like larger bodies like ANSCA, Australian guidelines, and the Royal College guidelines, they recommend against using fentanyl patch in acute pain because you cannot titrate that effectively. So some of the new guidelines stress on using the short acting now, as much short acting opioid for the immediate post-op pain relief so that you can titrate and stop it in time. So next thing this guidelines comment on is the route of drug administration. Of course, from principle base, we should use oral route as much possible whenever it is available. However, in the emergency colorectal surgery, it is not always possible to use oral route. What these guidelines do suggest that do not use intramuscular use. Do not use IM medications for pain relief. Stop using IM pethidine. Epidural is still one of the gold standards, and they use a blanket statement that if feasible and it's not delaying the emergency procedure, it should be used, epidural and regional anesthesia. And these guidelines recommend against using these agents, magnesium, benzodiazepines, tramadol, and ketamine in the neuroaxial regional anesthesia due to safety concerns. Is still with me, everybody here listening? Just checking, was online is a bit. Sadaf?
Yes, sir.
Yeah, okay, good, good.
Very interesting presentation, fresh knowledge.
Okay, so next comment is about perioperative nerve blocks and local infiltration. Again, I'm not going into each block in detail. I'm telling what these guidelines suggest. We all know for abdominal surgeries, tab blocks, rectus sheath blocks, they are good. But what these guidelines are suggesting that timing of these blocks should be performed before the surgery. Again, all of this is in the context of preemptive analgesia has been focused. What they have found that if you start the intervention, pain relief, analgesic intervention before the surgical insult, that has got more advantage. And continue it, of course, the effect of this intervention will continue preventively as well, as long as the local anesthetic duration of action is going on. Local wound infusions and infiltration have weak recommendation. Nevertheless, if you do not have any other modality available, still use it rather than not using like local anesthetic infiltration into the wound. However, better than that are the tab block, better than that are the epidurals. Another big area related to opioid use in the immediate post-op period is the constipation. So this paper suggested some of the guidelines or evidence-based modalities to tackle with the constipation, and our colorectal surgeons hate this aspect when we start patients on opioids. So one thing is, of course, multimodal anesthesia, because by using that, you are reducing the opioid amount. Another big area is use regional as much as possible, again, with the aim of reducing the opioid. Enhanced recovery protocols are encouraging caffeinated drinks to reduce the time to first flatus and first bowel movement and GI recovery. And a big thing is intravenous lignocaine in colorectal surgery, which is proven to improve the gut motility in the colorectal context. So in a nutshell, like so many tools are available, you have to define what works in your particular setup and in your particular patient, and then tailor it according to your clinical expertise, what your nurses can manage. So having no equipment, for example, if your setup does not have epidural pumps, does not negate the right that you can still do a lot for these patients by using a multimodal drug regime, by using an appropriate combination with regional anesthesias, and you can think of innovative ways how you can make things preemptive, yet also continue it to be as preventive. So that is the key take-home message, and from this paper for me and for all of you. And the second main one is in the assessment, focus on the functional outcome, functional goals, for rather than concentrating too much on the pain scores. I'll just quickly whiz through this paper. I know we are running short on time and it's Ramadan, and a third time will be falling upon you shortly. Are we good for next 10 minutes, Sadaf?
Yes, sir.
So I'll just quickly wrap up with this another useful paper. I selected this because ketamine, as far as I understand, is very freely available in Pakistan, correct?
Not now.
Not now, is it short? Oh. Anyways, hopefully, I mean, the reason for me to select this, that I thought that ketamine is available. And second main reason was that advantage of ketamine not requiring that much monitoring in terms of airway and modalities. So there was a recent paper in 2018 which came out from the American group, which published these guidelines.
It is available in some hospitals, and it is not available in the market. At least hospitals can buy it. It is not available.
Yeah, so we are talking all in context of inpatient pain management, inpatient acute pain management, that how we can use what is available in our setups. And since there was a very recent guideline on that, so I thought it is useful to update you all on that. And what you can take out of this in your own local setups, you can just produce a local protocol or guideline to for routine post-op use, you know, because this guideline answers some very key questions, especially in terms of monitoring. So these are the areas which this paper about ketamine talks about, that what are the indications for use, what dose should be used for analgesia, is it really beneficial for multimodal regime, or is it beneficial as a sole agent? How about intranasal use or other routes, oral route? Dr. Tahir Bashir might be interested in that. So they have commented on that. What are the contraindications and which areas it should be used in, like who should be monitoring such patients? First question these guidelines ask that which patients and which acute pain conditions should be considered for acute for ketamine treatment. So the statements for that were relatively broad, that any surgery where you expect the pain to be severe, you can justify using ketamine from the evidence base. So that is one group. The second group is any patient who could be opioid dependent. That group, I don't know whether it is common in Pakistan or Asian region or not, but in other areas of the world, it is very predominant group as well. Or any complex chronic pain patient coming for abdominal surgery or major surgery, you can justify using ketamine. And third main group is any patient who is at high risk of obstructive sleep apnea. So this is another very practical group. And the rationale for that group was to reduce the amount of opioid and ketamine's advantage of not affecting the airway. Sorry, in the background, there's a fire alarm going on. So I hope it does not disturb my voice quality too much. Is it my voice coming okay, or do you want me to wait until the alarm goes off?
Yes, sir, it's fine.
Can you hear me still? Yeah.
Fine, sir.
I may have to pause for a second because it's a continuous alarm, so I just have to quickly check as part of the.
We can't hear that. We can't hear that alarm. Carry on. Continue.
No, but if it is real fire, then I am expected to leave. You know. just give me 1 second. I'll be back in 1 second. Okay. Just as a protocol, we are just supposed to check. Just give me 1 second. Yeah, the alarm has shut off, so that's fine. I'm back. Okay, so first part was about indications. So any please or confusion about that area? So basically, any major surgery, any complex chronic pain patient, and third group is patients with obstructive sleep apnea or high morbidly obese patients. all fit in this criteria for giving ketamine as a painkiller. Second main question these guidelines ask about was what dose should be given. And the term which is used by the paper is obviously sub-anesthetic. So analgesic dose, when we say that, it is always sub-anesthetic. And what this paper tried to define that what is a sub-anesthetic dose, what evidence support, what range should be used for the acute pain. As a conclusion, what they came up with that whenever you give ketamine, the bolus should never exceed 0.35 milligram per kg, although we give much less than that. And if you're giving infusion in acute pain, it should not exceed 1 milligram per kg. And that limit, important thing they have mentioned, in settings without intensive monitoring. So that is a very big advantage, that they accumulated all the studies of various papers and concluded this safe range where you do not necessarily need intensive monitoring of the patient. So even in the ward setup, doses were given safely. However, inter-individual differences do exist. So third main question was about whether ketamine should be added as an adjunct to the opioids, like mixing ketamine with fentanyl, mixing morphine and ketamine, mixing lidocaine and ketamine. So what they found that overall, when you add ketamine to existing pain modalities, it overall reduces pain. For example, if a patient is on a PCA and you're adding ketamine, they found that it reduced nausea, vomiting, it reduced the post-operative length of stay. So randomized trialed patients who use sub-anesthetic doses ketamine experience almost comparable pain control with fewer effects and 45% reduction in morphine consumption, which is quite big. So I'll not go on to this table, is quite busy, but I'll just, this is basically telling various advantages of ketamine they studied by introducing in the regime. Fourth main questions are which patient we should not be using ketamine under in the acute pain setting. So the problem with this area was that all the contraindications for ketamine are mainly for the anesthetic doses. They could not find any papers where these contraindications were studied in detail. You know, the usual contraindication that we talked about, the patient with major cardiovascular disease, pregnancy, patient with acute psychosis, high intracranial pressure, high intraocular pressure, major hepatic dysfunction. So these are all the contraindications which are for the anesthetic doses. However, because there were lack of papers looking at sub-anesthetic analgesic doses, therefore they cannot conclude. And for safety purpose, the guidelines recommended that still you continue to have these contraindications as well, although all these contraindications are actually for the anesthetic doses. But still, for safety says, we are supposed not to use in these conditions. Last bit was that which people should look after these patients who are on sub-anesthetic ketamine infusions. What the guidelines suggest that nurses should have ACLS qualification and should have an additional training module done on sedation. So any centers who are running these, they don't necessarily have to have HDU environment, but they should, a physician or a nurse who is looking after these patients should have these two criteria met: the sedation module completed as well as ACLS certification. Last bit is about non-parenteral ketamine for acute pain management. For oral ketamine is extremely limited evidence, so they could not conclude anything for that. Intranasal ketamine, interestingly, they said that was very well tolerated and provides superior pain relief For active competitors, the groups that they studied mainly were small groups in pediatric population, where they used it for ease of cannula insertion. So final conclusion is that intranasal ketamine is beneficial for acute pain, providing not only effective analgesia, but also amnesia. Scenarios were in whom IV access was difficult. So it was not a very broad spectrum they studied into. Oral ketamine, they could not find robust evidence. However, anecdotal reports suggest that it's a short-term benefit in individuals with acute pain. Last bit is that, is there any advantage if you use ketamine as a PCA? Overall, they found that is limited benefit if you use ketamine as a PCA as a sole analgesic agent. So moderate evidence exists if you add ketamine to an opioid-based IV PCA, because then you reduce the amount of opioid, but not as a sole analgesic agent. In summary, we talked about indications, we talked about the dosing regime, relative contraindications, and which personnel can use it. I can send this paper and you can produce local guidelines at your end, because at least ketamine advantages that one of the things which came out from this paper, that this dosage regime is not in a highly monitored area, and it was safe to use that without any major side effects. Right, thank you very much, guys. I'm sorry, it has been Ramadan and fasting time, so it's a huge area, it's a big area. I've only covered a couple of relevant recent papers which came up, and my plan was mainly to use areas which are broadly applicable, and then we can discuss and apply to your area rather than telling anything very specific, because every hospital environment is different and you have to tailor according to your own setup. So thank you very much. We'll just have some discussion now.
Thank you very much, Usman. Thank you, Usman, for the excellent presentation. You covered almost every aspect and with the latest references. It was not a traditional lecture. It was it's full of information, full of recent information. Excellent presentation. Thank you very much.
So even we, like these papers are relatively recent. So even we at our setup in King Faisal here are changing some of the scopes. Like this functional pain score is quite useful, you know. We always keep telling patient that, okay, you will have no pain, no pain. So we are moving away from this now. So now we are functional pain score, you add it into your regime, and then you just measure your department outcomes based on the functional outcomes rather than pain scores itself. And preemptive was another big thing for me as well, learning wise, that there's much more focus on starting these before the surgical insult.
Yes, preventive. Preventive is now recommended in place of preemptive, that the analgesic should continue in the post-op period.
Continue as well, yes.
Should continue in the post-op period to prevent central and peripheral sensitization. That
Absolutely.
is the key factor. Ketamine,
but what they are focusing, what they are stressing, that preventive modality you start preemptively, that is ideal, that it is combines both, you know. So you do continue that post-operatively as well. Do not just only do it before the surgical insult.
Yes. But what we used to do in few months back, that we start with preemptive by using ketamine or tramadol, whichever it is, and then give 1/4 of the dose of ketamine during closure. It also gave good results in the post-op period. Better pain relief. Instead of giving ketamine in the post-op period, I started giving 1/4 of the dose in the while the peritoneum was being closed, so the wound was being closed. So it produced good results.
No, absolutely, absolutely. So as long as the fellows and the residents just keep that in mind, that not having a particular modality available is not an excuse not to give analgesia you can still provide very good quality acute pain relief in the setups you have based on these papers. Like even if you don't do any epidural, if you don't have kit available, you can still run lignocaine infusion, ketamine infusion, and give a good pain relief first, because first 48 hours are very important in terms of acute pain post-op management. Because after 48 hours, most of the studies show that most of these modalities have equal effect. So it is the first 48 hours which is critical in the acute
Yes.
pain context.
True.
So you can throw as much as on the patient in the multimodal regime available in your setup. And this is the purpose of these talks, that it stimulates you to produce your own local guidelines. And then what you do is you produce local data to find out, okay, what has been the effect in the next 6 months. I've introduced this ketamine regime. Let's see what has been the effect in my center on reducing the amount of opioid they have used, in reducing nausea, vomiting, in reducing the length of stay. So 3 or 4 key outcome measures you can select after introducing each of these things, and take it as a quality improvement project in your own setups.
Yes. Great. Anybody
So any
wants
questions from
to
fellows?
want to ask a question from Usman? Any participant?
Yes, Assalamu alaikum. Tahir here.
Assalamu alaikum, sir. Great to have
Usman
you,
Bashir,
sir.
how are you? Yeah.
Excellent. Mashallah.
Thank you very much. Thank you. Very nice lecture. Actually, in acute pain management, in our lectures, and you also, we just cover our part, like preemptive and intraoperative or immediate post-op. But acute pain management also includes the post-operative period, 2 or 3 days, what patient stays in the hospital. And
Absolutely.
that is very important aspect I observed repeatedly here. We don't own those patients post-operatively in the ward. And post-op analgesia in the ward and discharge medicine is prescribed by the surgeon. And again, if you collect data, that will be very interesting that either that analgesic medication is inadequate or the dosage is inadequate. And interestingly, even orthopedic surgery, which is very, very painful, all the medications are prescribed as PRN. So that gives very inadequate analgesia to the patient.
Absolutely.
So then as acute pain team, next day or for next 2-3 days, we usually modify the medication here. So what is your statement about this?
Yeah, I think, and that's, couple of the papers which I included, but I did not have time to go through those, was overall related to this aspect, which you are saying that we start taking charge of all these discharge medication worldwide. In our setup, Dr. Tahir, the problem is that the quality of discharge medication is very poor by the surgeons. It's not the opioid crisis as such. Whereas the world over, the reason they started taking over this area because they were giving opioids in abundance at discharge. And that's why they started coming with papers like this, that perioperative opioid minimization, how to do these things. But I totally agree that when we talk about these preventive analgesia, we are extending up to day 3-4 of post-op time period. But where I think most of, even in developed world, in UK as well, the expertise where we lack is the discharge medications. A lot of very well set up organizations are also not good at this. In a Caesar department, I'm talking about, that by the time patient is discharged from acute pain service, we lose track of that patient. In some of the centers in UK, what they have started to counteract this, to open transitional clinics. They have named as transitional clinics, where acute pain services writes the discharge medication for the patient. They call the patient back after 1 week so that they can stop those medications, they can look at those medications. So in those setups who have the luxury of transitional clinics run by the acute pain team or the pain team, where the routine post-op patient take-home medications are being prescribed by anesthesia department. But when they're prescribing it, they are calling the patient back in their transition clinic, not by the surgeon. So that is one of the way forwards, I think, as a solution, which is lacking in a lot of centers, including ours. This is a shortcoming, you know.
Yeah, that will be very extended service, and you know the staff and the time and all these things. It is not possible for an
I mean, some centers in UK are doing it. Some centers have started doing it. If you type transition clinics, this is the concept behind it, that anesthesia takes charge of discharge medication. But when they discharge, for example, if I've discharged somebody on tramadol and pregabalin for major laparotomy, minimize, then I do want to see them to stop it as well. So that is where the need for transition clinic comes, you know. So you cannot start all these gabapentinoids. They're very well and good, but you have to have a check and a stop point on these, you know.
Yeah. Thank you so much.
Dr. Tahir has raised very pertinent point that we also face this problem, that we are concerned only up to post-op period. So when they are discharged to the room from recovery or PACU, suddenly the level of anesthesia drops, level of pain relief drops. So we also sometimes we often receive complaints from surgeons that why don't you manage in the room as well? So then the services has to be expanded. But there's a complaint of patient that in the post-op period we are okay. Since we came in the room, we face problem for the pain relief. This is a very good point which Dr. Tahir Akbar has raised.
Absolutely. So problem is twofold.
Yes, sir. Yeah, sorry, Dr. Usman. Yeah, actually, yes, sir. It is actually two things. Either we extend our service to the post-op next 2-3 days, which is usually not possible for routine hospitals, all the hospitals. We have here a very good acute pain service, and we modify the medication next day if needed. And the second point is, again, we gave lectures to certain departments, like for orthopedics, it is very difficult to teach them. I mean, how to prescribe post-op pain medication. I mean, even simple paracetamol, they prescribe as PRN, which is so funny. I mean, you give regional blocks, patient is very comfortable for 10-15 hours, then they start having pain, which is very severe and sudden pain. So they don't cover it. So either to address individually those departments, surgery, orthopedics, like that, or we extend our service. So these are the two possibilities.
I think the practical solution, like you have worked all over the world as well, it is very difficult to buy in unless the surgical specialty itself is very interested in pain. They are not interested overall in managing the pain. So in the rest of the world where things have worked out, anesthesia or pain department has taken over an extended role just to sort this problem out. So that is a more pragmatic, practical solution. I think that the anesthesia or acute pain department itself takes the ownership beyond the post-op recovery area, beyond the recovery area. First step, that is first 2 to 3 days by setting up an acute pain team. And the second step is then to set up a transition short-term follow-up clinic. If any patient is being discharged, if the discharge medication are being taken over by the acute pain team, you know. So these two-step approach can be the solution. Training the surgeons, I'm sure there's no surgeon sitting here at the moment.
Yes.
It's the same all over the world, I think.
It is true.
Great. Thank you very much, everybody. It has been lovely seeing all of you back. Salam in regard from Madina Munawwara. And happy Ramadan to everybody. It is a very blessed Ramadan going on. We welcome and hope to see you here some point.
Inshallah.
Once again, Usman, thank you very much for sparing your time. On behalf
Thank you very much.
STSP, we are thankful to you. And we are missing you. After this talk, we are missing is further increased. Okay.
No, inshallah, we'll create some guidelines from ST platform to initiate some of these aspects. Thank you very much.
Thank you.
Thank you so much.
Uh,